Anxiety, obsessive-compulsive, and related disorders. An understanding of anxiety and anxiety defense mechanisms is basic to the practice of psychiatric nursing. Anxiety is the most basic of human emotions to which no one is a stranger. Dysfunctional behaviors are often a defense against anxiety. When the behavior is recognized as dysfunctional, interventions to reduce anxiety can be initiated by the nurse. As anxiety decreases, dysfunctional behavior will frequently decrease as well. These are a list of our objectives that we'll cover in this chapter and in this presentation. So anxiety, the basic definition of anxiety is that it's an emotional response to anticipation of danger, the source of which is largely unknown or unrecognized. Anxiety is a necessary force for survival. It is not the same as stress. A stressor is an external pressure that is brought to bear on the individual, whereas anxiety is a subjective emotional response to that stressor. Anxiety may be distinguished from fear in that anxiety is an emotional process, whereas fear is more of a cognitive process. In historical times, anxiety was once identified as a physiological symptom, focusing largely on the cardiovascular system. Freud was the first to associate anxiety with neurotic behaviors. And for many years, anxiety disorders were viewed as purely psychological or purely biological in nature. Epidemiological statistics show that anxiety disorders are the most common out of all the psychiatric illnesses we study. They're more common in women than men, and minority children and children from low socioeconomic environments are at risk. A familial predisposition probably exists as well. So how much is too much? When anxiety is out of proportion to the situation that it is creating. When anxiety interferes with social, occupational, or other important areas of functioning, it also is too much. Whereas this is a direct correlation to the patient's inability to perform their ADLs. And in the first bullet, a totally unrealistic level of anxiety related to the actual threat. It's difficult to differentiate between normal and abnormal anxiety, as normality is determined by societal standards. However, anxiety is generally considered abnormal or pathological if it's out of proportion to the situation that's creating it, or that it interferes with our ADLs, as I said. It is clear that when anxiety becomes excessive and persistent, humans respond to a variety of ways that are likely a complex interaction of genetic vulnerability, biochemical influences, and environmental factors. So, assessment. With panic disorder, which is characterized by recurrent panic attacks, the onset of which are unpredictable and manifested by intense apprehension, fear, or terror, often associated with feelings of impending doom and accompanied by intense physical discomfort. This may or may not be accompanied by agoraphobia. So, these symptoms can come on very suddenly and often unexpectedly. And the role of organic factors to the etiology has been ruled out. Some of the symptoms that we see with panic attacks are sweating, trembling, shaking, shortness of breath, chest pain or discomfort, nausea or abdominal distress, dizziness, chills or hot flashes, numbness or tingling sensations, derealization or depersonalization, fear of losing control or going crazy, and fear of dying. These correlate directly with the DSM-5's criteria for diagnosis. In many cases, specifically with derealization, which is a feeling of unreality, and depersonalization, which are feelings of being detached from yourself. Sometimes people describe this as observing actions happening to them from outside their body. Many patients that have a panic attack, sometimes for the first time and sometimes recurrently, will actually call 911 or seek medical attention in an emergency room where they believe they are having a heart attack. These symptoms are very similar to symptoms of an MI, such as the shortness of breath, chest pain. Patients can have tachycardia, trembling, shaking, sweating. First off, what we do if that happens is we rule out any kind of cardiovascular connection. So they will do cardiac enzymes, they'll do a 12-lead EKG, and they'll monitor the patient to rule out any signs of a heart attack. And then they will begin to look at other causes which could be related back to a panic attack. Generalized anxiety disorder is characterized by persistent, unrealistic, and excessive anxiety or worry, which have occurred more days than not for at least 6 months and cannot be attributed to a specific organic factor such as caffeine intoxication or hyperthyroidism. The anxiety and worry are associated with muscle tension, restlessness, and feeling keyed up or on edge. The symptoms of generalized anxiety disorder are intense enough to cause clinically significant impairment in social, occupational, and other important areas of functioning. The individual often avoids activities or events that may result in negative outcomes and spends considerable time and effort preparing for those activities. Anxiety and worry often result in procrastination in behavior or decision making, and the individual repeatedly seeks reassurance from others. Panic and generalized anxiety disorders. Some of the predisposing factors may be, from the point of view of a psychodynamic theory, is that the ego is unable to intervene between the id and the superego. Overuse or ineffective use of ego defense mechanisms results in maladaptive responses to anxiety. From the lens of cognitive therapy, faulty, distorted, or counterproductive thinking patterns result in anxiety that is maintained by mistaken or dysfunctional appraisal of the situation. There are many biological aspects such as genetics, anatomical, biochemical, and neurochemical effects that could play a role in predisposing people to panic and generalized anxiety disorder. Genetic vulnerability to panic disorder has been supported by family and twin studies. A concordance rate of identical twins is 30%, and the risk of the disorder in a close relative is 10 to 20%. Structural brain imaging studies in patients with panic disorder have implicated pathological involvement of the temporal lobes, particularly the hippocampus and the amygdala, and the frontal cerebral cortex have also been noted in clients with anxiety disorders. There's also been abnormal elevation in blood lactate have been noted, and likewise infusion of sodium lactate into clients with anxiety neuroses produce symptoms similar to a panic disorder. There's stronger evidence that exists for the involvement of neurotransmitter norepinephrine to the etiology of panic disorder. Norepinephrine is known to mediate arousal, and it causes hyperarousal and anxiety. This fact has been demonstrated by notable increase in anxiety followed by administration of drugs that increase the synaptic ability of norepinephrine. And these neurotransmitters, such as GABA, are thought to be decreased in anxiety disorders. Phobias. A phobia is a persistent, intensely felt and irrational fear to a specific object, activity, or situation that results in compelling desire to avoid the feared stimulus. Agoraphobia is the fear that some patients have of being in open shops and markets, although it may be more related to fears of being vulnerable or in a less secure environment. The individual experiences fear of being in places or situations from which escape might be difficult or in which help might not be available in the event that a panic symptoms begin to occur. Impairment can be severe, and in extreme cases, the individual is not able to leave his or her home without being accompanied by a friend or a relative. Some examples of this may be traveling on public transportation, shopping in a mall or in a grocery store with a lot of people, being around a crowded area such as a parade or a theme park. Social anxiety disorder is an excessive fear of symptoms in which a person might do something embarrassing or be evaluated negatively by others. The individual has an extreme concerns about being exposed to possible scrutiny by others and fears social or performance situations in which embarrassment might occur. In some instances, the fear may be quite defined, such as a fear of speaking or eating in a public place, fear of using a public restroom, or fear of writing in the presence of others. In other cases, the social phobia may involve general social situations such as saying things or answering questions in a manner that would provoke laughter on the part of others. There are also specific kinds of phobias, which is a fear of a specific object or a situation that could cause harm, but the reaction of them is excessive, unreasonable, and inappropriate. The phobic person may be no more anxious than anyone else until exposed to the phobic object or the situation. Exposure to the phobic stimulus produces overwhelming symptoms of panic, including palpitations, sweating, dizziness, and difficulty breathing. These symptoms may occur in response to the individual's merely thinking about that phobic stimulus. Even though the disorder is relatively common among the general population, people seldom seek treatment unless phobia interferes with their ability to function. Some specific phobias have been classified according to the phobic stimulus. A list of some are in your text. Some specific ones are types of animals, natural environment type, blood injection, injury type. Freud's characteristic theory associated phobias with a symbolic displacement of anxiety that is rooted in castration anxiety. Modern-day psychoanalysts believe in the same concept of phobic development, but believe that castration anxiety is not the sole source of phobias. They believe that other unconscious fears may also be expressed in a symbolic manner as phobias. Some theorists hold that fears are conditioned responses and they are learned by imposing rewards for certain behaviors. In the instance of phobias, when the individual avoids that phobic object, he or she escapes that fear, which is indeed a powerful reward. Phobias also may be acquired by direct learning or imitation. Cognitive theorists believe that anxiety is a product of faulty cognitions or anxiety-inducing self-instructions. Two types of faulty thinking have been investigated: negative self-statements and irrational beliefs. Cognitive theorists believe that some individuals engage in negative and irrational thinking that produces anxiety reactions. The individual begins to seek out avoidance behaviors and prevent the anxiety reactions and phobias result. Innate fears represent a part of the overall characteristics and tendencies with which one is born that influence how he or she responds throughout their life to specific situations. Innate fears usually do not reach phobic intensity, but they may have the capacity for such development if reinforced by events in later life. And then certain early experiences may be the stage for phobic reactions later in life. Some researchers believe that phobias, particularly specific phobias, are symbolic of original anxiety-producing objects or situations that have been repressed. Medical conditions that produce anxiety symptoms include cardiovascular issues, such as myocardial infarction, congestive heart failure, and mitral valve prolapse. They could include endocrine disorders such as hypoglycemia, hypo or hypertension, respiratory conditions such as chronic obstructive pulmonary disease and hyperventilation, and neurological conditions such as complex partial seizures, neoplasms, and encephalitis. We also have substance-induced anxiety disorder, and again, these are pretty easy to remember because they are directly related to some substance that has been ingested by the client. And so one of the most common ones is caffeine. So if we have a patient that has, anxiety that is directly attributed to this substance of caffeine, we need to reduce the caffeine intakes safely of this person. So we will, taper this person off the caffeine if they have been, on a high level of intake of caffeine for quite some time. We'll need to decrease that amount slowly to avoid them having significant symptoms. In addition, the same will go with amphetamines and alcohol and cannabis. Obsessive-Compulsive Disorder. The manifestations of obsessive-compulsive disorder include the presence of obsessions, compulsions, or both, the severity of which is significant enough to cause distress or impairment in social, occupational, and other important areas of functioning. The individual recognizes that the behavior is excessive or unreasonable, but is compelled to continue the act. Common compulsions include hand washing, ordering, checking, praying, counting, and repeating words silently. Obsessions are intrusive thoughts that are recurrent and stressful. Although they are recognized by the individual as irrational, they continue to be repetitive and cannot be ignored. Now, the compulsions are a repetitive ritual behavior or mental acts that the individual feels driven to perform, which are intended to reduce the anxiety associated with those obsessive thoughts. So, the compulsion is a way for this patient, this client, to actually reduce the presence of those persistent thoughts. Body dysmorphic disorder. This disorder is characterized by the belief that the body is deformed or defective in some specific way. The most common complaints involve imagined are slight flaws of the face and hands, such as wrinkles and scars, shape of the nose, excessive facial hair, or facial asymmetry. These beliefs are differentiated from delusions in that the individual with a body dysmorphic disorder is aware that their beliefs are exaggerated. In some cases, though, people with body dysmorphic disorder also develop psychotic disorders. People with body dysmorphic disorder often have other comorbid mental disorders such as major depressive disorder, anxiety disorder, or psychotic disorder. Trichotillomania or hair pulling disorder. This is the recurring pulling out of one's hair that results in hair loss. The impulse is preceded by an increasing sense of tension, and the results in the sense of a release or gratification from pulling out the hair. The most common sites for pulling hair are the scalp, the eyebrows, and eyelashes, but many occur in various areas of the body where hair grows. Comorbid psychiatric disorders are common with trichotillomania. Some of these involve mood disorders, eating disorders, anxiety disorders, substance abuse disorders, and personality disorders. So the next disorder is hoarding disorder. It's defined as having persistent difficulty discarding or parting with possessions regardless of their actual value. Additionally, this diagnosis may be specified with the excessive need for continual acquiring of items. In previous editions of the DSM, hoarding was considered a symptom of OCD. However, in the newest edition of the DSM-5, it's been reclassified as a diagnostic disorder. Individuals with this disorder collect items until virtually all surfaces within the home are covered. There may be only narrow pathways winding through stacks of clutter in which they can travel. Some individuals also hoard food or animals, keeping dozens or hundreds of pets, often in unsanitary conditions. The severity of these symptoms, regardless of when they begin, appear to become more severe with each decade of life. Associated symptoms include perfectionism, indecisiveness, anxiety, depression, distractibility, and difficulty planning and organizing tasks. In addition to OCD, hoarding is associated with high comorbidity for dependent, avoidant, and schizotypal and paranoid personality disorders. Predisposing factors to OCD and related disorders. So with the psychoanalytic theorists, they propose that individuals with OCD have weak, underdeveloped egos. The psychoanalyst concept views clients with OCD as having regressed to an earlier developmental stage of the infantile superego. Regression to this pre-occipal anal sadistic phase, combined with use of specific ego defense mechanisms, produces the clinical symptoms of these obsessions and these compulsions. Now, the learning theorists explain obsessive-compulsive disorder as a conditioned response to a traumatic event. The traumatic event produces anxiety and discomfort, and the individual learns to prevent the anxiety and discomfort by avoiding that situation with which it's associated. This type of learning is called passive avoidance. When passive avoidance is not possible, the individual learns to engage in behaviors that provide relief from the anxiety and discomfort associated with the traumatic situation. Psychosocial influences related to trichotillomania include stressful situations, disturbances in the mother-child relationship, fear of abandonment, recent object loss, and possible childhood abuse and emotional neglect. Biological aspects could include there could be some possible link with trichotillomania to genetic background, could be some possible abnormalities in the basal ganglia with OCD, and physiology, as some individuals with OCD exhibit electroencephalogram changes, and there could be some biochemical factors that are possibly decreased in serotonin with OCD and with body dysmorphic disorder. So with our nursing diagnosis, these are some common ones that we give patients that exhibit some of the symptoms we discussed, such as panic, anxiety, powerlessness, fear, social isolation, ineffective coping, ineffective role performance, disturbed body image, and ineffective impulse control. Our outcomes for clients is that probably our number one outcome, most important, is that the client is able to recognize signs of an escalating anxiety and that they're able to communicate those with us so that we can intervene before they reach the level of panic. We also want to maintain anxiety at that manageable level and make independent decisions about their life situation. They can function adequately in the presence of a phobic object or situation without experiencing panic anxiety. This may take some time because exposure to this phobic object or situation is still going to elicit some discomfort with patients even after possibly several weeks or even months, depending on the patient, of exposure to that object. Verbalizing a future plan of action for responding to the presence of a phobic object or situation without developing panic anxiety. So we want them to be able to formulate a plan. So if their phobic object is a snake, that if they were to be exposed to the snake, what is their action going to be? You probably are not going to have to tell them to remove themselves from that area or that situation. They're likely going to do that. But how can we have them communicate with others around them or remove themselves without reacting at a panic-like anxiety level? That's going to take some work. That they're able to maintain anxiety at a manageable level without resorting to those ritualistic behaviors that they use for the compulsions. And we want them to verbalize that they have a realistic, appropriate view of their body image, positive in nature. And we also want them to demonstrate that they have adequate strategies for coping with stressful situations, especially related to trichotillomania. So some of the interventions that we may do is with panic or anxiety, we may have the client maintain calm, non-threatening approach. We may keep the immediate surroundings low in stimuli and teach the client signs of escalating anxiety. One of the key things here is to keep the stimuli low. So this is something that you will see employed in inpatient psychiatric settings where there's not a lot going on. There's not going to be music playing overhead, TVs going loudly in various different rooms, games going in this room. They try to reduce the stimuli by having, for instance, in the day room, they have one television. They likely will turn the television off if it's time for game time, eating, group. We like to reduce the stimuli in these environments to not elicit anxiety. Fear, we want to include the client in making decisions, encourage the client to explore underlying feelings. Ineffective coping, we want to initially meet the client's dependency needs, but provide a structured schedule for their activities. With disturbed body image, we want to help the client see his or her body image as a positive, but eventually non-distorted. We want to involve client in activities that reinforce their positive self-image. And we may refer them to support groups for people with disturbed body image. And then ineffective impulse control. Probably one of the most important things here is to practice stress management techniques. Convey a non-judgmental attitude and offer support and encouragement. With education of the family and the client, we want to teach them about the disorder, the causes, and the symptoms. If medication is ordered, we want to talk to them about possible adverse effects, the length of time for that medication to take a full therapeutic effect, and what to expect from the medication. Also want to tell them that the medication and taking the medication one time or for a week is not going to cure the disorder, but will probably have to be taken for quite some time. Management of the illness, we want to teach ways to interrupt escalating anxiety, and we want to teach relaxation techniques. Support services, we always want to teach patients about crisis hotlines and support groups available to the patient and their families, and that individual psychotherapy is often necessary for the best outcomes related to anxiety. Then we want to evaluate what we did, how that worked. Did the client's signs and symptoms of anxiety decrease with our interventions or not? And how do we manage that plan of care to reevaluate and reintroduce a new intervention to meet our goal? Other things that we look at is, are they able to be in the presence of the phobic object without experiencing panic anxiety? Are they able to verbalize a positive body image Those are our overall evaluations for the client. Are we moving toward meeting those goals? Some of the treatment modalities used are individual psychotherapy, which works one-on-one with a therapist and the client to actually uncover and determine the root causes of anxiety-provoking agents. There also could be cognitive therapy, which strives to assist the individual to reduce anxiety responses by altering cognitive distortions. And there could be behavioral therapy such as systematic desensitization. This is a link here for you to watch an overview video on systematic desensitization. It is a therapy that we do use at Seton Shoal Creek, and I'd like you to just be mildly familiar with it. And then also psychopharmacology. These are some of the anti-anxiety agents used. Klonopin is probably one of the most common. It's particularly effective with panic disorders. Xanax is another that is fairly common. Ativan as well. Those are more short-acting anti-anxiety agents. And then this is more continuation for some of the pharmacology that's used with specific disorders. So you'll see we typically use anxiolytics and antidepressants, as well as some antihypertensive agents such as propranolol can be used with panic and generalized anxiety disorder. Propranolol is one of the drugs that's used with people that have testing anxiety or performance anxiety. One of the most famous people is that has used propranolol was, sorry, I'm missing her name now, but she was in Yentl, Barbra Streisand. Barbra Streisand's famous for speaking about her use of having performance anxiety and using that medication. So these are some other medications that are used in conjunction with the various disorders that we discussed today. Be sure and have some working knowledge on what could be a danger, when to stop taking the medication, not to stop taking it abruptly. Can the medication be mixed with anything over the counter? Remember our MAOIs, and that we are worried about tryptophan, and trying to think if there's anything else I need to mention to you. Remember about serotonin syndrome and neuroleptic malignant syndrome, and what we might see in patients physiologically that may be an indicator that they have that may be suffering from those issues that we may need to intervene as an emergency in.